Hello, welcome to the webinar on the impact of the Inflation Reduction Act on new treatments for mental illness. My name is Burton Eller. I do the public policy, advocacy, and legislation for the National Grange. I'm very pleased to have you with us on this webinar presented by the National Grange and Rural Mines and sponsored by Grange Advocacy. Since our founding in 1867, the National Grange has worked to advance the political, economic, and social interests of the nation's farmers and all engaged in agriculture. Today, we remain active in advocacy to represent the interests of Grange members, their neighbors, and others who live in rural America. While the information being presented today about the Medicare prescription drug coverage changes in the Inflation Reduction Act, it's relevant to many people, but it's especially relevant to the Medicare beneficiaries and pharmacists living in rural America. As you'll hear, many patients prefer taking medication as a pill rather than an infusion or injection. Since patients are typically required to travel to a medical facility for infusions and injections of medications, this is especially important concern for patients who live in rural areas and may not have access to a medical facility or an infusion center. We appreciate our long-standing partnership with Rural Mines as we work together to improve the state of mental health and rural communities across the country and to address rural mental health inequities. Overall, health includes mental health, which is why addressing the epidemic of mental illness in rural America is a priority for both the Grange and Rural Mines. Thank you for joining us today. I'll now turn it over to Rural Mines founder and chairman, Jeff Winton.
Thank you very much, Burton. Rural Mines is the only national nonprofit organization focused on solely providing the 46 million people in rural America with free information and resources to confront rural mental health challenges and the stigma that surrounds mental illness. This webinar is the second in a series of 3 webinars focused on Medicare insurance coverage changes, along with the importance of pharmacies across rural America. We recognize that adequate healthcare insurance is necessary to minimize the anxiety and stress from managing a physical illness, a mental illness, or both. This 45-minute webinar will feature a presentation by Candace DeMatteis, Policy Director for the Partnership to Fight Chronic Disease, which will be followed by a question and answer session moderated by Matt Duckworth, Vice President of Government Relations with Heart Health Strategies in Washington, D.C. We respect the privacy of everyone who is watching the webinar today. Please know that your name and image will not be visible to others in the audience. Please enter any questions that you may have into the Q&A box, and we will answer as many as possible during the Q&A session that will follow the presentation. Also, if at any time you or someone you know is experiencing a mental health crisis, please call or text 988 to speak with a trained mental health counselor at the National Suicide Prevention Lifeline. At this time, I'm pleased to introduce Candace DeMatteis, Policy Director for the Partnership to Fight Chronic Disease, or PFCD for short. PFCD is committed to both raising awareness of the human and economic toll chronic illnesses exact and highlighting solutions that are addressing these challenges equitably for all affected. As a policy director, Ms. DeMatteis is responsible for monitoring health policy developments relating to chronic disease prevention and management, including many aspects of healthcare reform, implementation, and continuing reform efforts within the U.S. public insurance programs, Medicare and Medicaid. Mrs. DeMatteis brings more than 20 years of public policy experience to PFCD. She holds a Bachelor of Science degree in mathematics from North Carolina University and received her Juris Doctor and Master of Public Health degrees from the University of North Carolina at Chapel Hill. Please join me in welcoming Candace DeMatteis.
Thank you so much, Jeff. It's great to be with you today, and congratulations on hosting these webinars on really important changes that are happening within Medicare. I am going to take a moment to share my screen, and while I'm doing that, I will also share that although my colleges are in my bio, what's not clear, although you may have guessed, is that I grew up in rural North Carolina, so I fully appreciate challenges with access to rural healthcare in rural areas. So as you know, there are a lot of changes involved with the IRA, or Inflation Reduction Act, that specifically, I mean, the act was huge and it touches many different areas of life, but there were a lot of changes in particular to Medicare. I understand that you had a webinar recently that went through a lot of the changes on the Medicare drug benefit. So I'm not going to focus on that aspect, but I'm going to talk more about the Medicare prescription negotiation program. And as you may have heard, that last week there was a big announcement about the first 10 drugs. So we're going to walk through that, but more importantly, we're going to talk about the implications for medicines that treat mental health conditions. As you can imagine, with any big change in policy, there are a lot of trade-offs made and decisions that have unintended consequences that could lead to big problems, as this cartoon indicates. The IRA included many, many changes to the Medicare program, and because Medicare is such a large program and covers a lot of people, it's having and will continue to have a big impact on people's access to medicine generally, not just people covered by Medicare. And one of the biggest changes is the new authority for Medicare to negotiate prescription drug prices for Medicare beneficiaries. And as I mentioned last Thursday, Medicare announced what it will pay for the first 10 drugs that went through that process. Those prices will take effect in 2026. Under the IRA, Medicare identifies which drugs it's going to put through the drug pricing program based on a few different factors. One is that they look at medicines that cost Medicare the most. But it's important to keep in mind that that's not just price, because a lot of people think, oh, they're just picking the priciest medicines. But as that first list of 10 shows, they really weren't the most expensive medicines on price. And in fact, quite a few of them didn't cost Medicare that much on a per person basis. But a lot of people are taking these medicines, so they do total up to a lot of costs for Medicare. But that's important to keep in mind, because again, I think a lot of people go in thinking, oh, it's price negotiation, so you're focused on price, when realistically they're focused on overall costs, and that has implications for access. Another key factor that they consider is how long has it been since the FDA first approved the medicine? And that starts the clock in terms of how long it's been since that first FDA approval for when it will be eligible for Medicare negotiations. Okay, so one of those big trade-offs that we were talking about is that the IRA set 2 different timeframes before a drug is eligible for pricing. And it depends on the type of medicine that it is. So there are small molecule drugs, and those are ones that we typically may think about when we think about a prescription medicine. So it's a pill, it's a patch, it's syrup, it's a capsule, things that we can pick up at a pharmacy or maybe even have mail ordered and delivered to our homes, that you sit down and take with a glass of water. So just about everybody has had experience taking one of these types of medicines at some point in their lives, and some people may be taking multiple every day. Small molecule medicines under the IRA are treated differently than the larger molecule medicines, large biologic medicines. And those you may think of are like infusions. Some people, when they think of cancer treatment, may think about chemotherapy, where you're sitting in a chair, you've got an IV in your arm for hours. those are the types of medicines that are large medicines, biologics. May involve injections, almost always involve traveling to a healthcare provider's office to take those medicines. They have to typically have a healthcare person involved in administering them because they require special handling. It's cold storage. They're very precise in terms of the dosing based on the individual and your reaction to the medicines. And the administration of them can take a healthcare provider's assistance to do it. This slide shows some of the, kind of when you're thinking about the difference between a small molecule all the way to a biologic medicine, there's a big difference in size. You can see the type of number of atoms involved. And I like this analogy that the people who put together this slide described it as. It's like a bicycle versus a business jet, both in terms of size, but also complexity. You've got, something that's, pedal power versus sophisticated engines. So they're very different types of medicines. Under the IRA, small molecule drugs are subject to drug pricing at 9 years after the initial FDA approval, compared to 13 years for biologics. And so that 4-year difference can make a big difference. Now, why did they do this? That's not really clear. I've heard, a lot of people asking that question. I've heard different answers, so I'm not going to pretend like I know why that decision was made. But what is clear and is becoming even more apparent is that this 4-year difference in timing is a huge reason that a drug company may prefer to develop a biologic medicine rather than a small molecule medicine. And we need both types. But the difference in timeline put into the IRA involving new research, involving small molecule medicines, it puts at it as a big disadvantage if you think about it. When it comes to 4 years difference in revenue, 4 years difference in ability to continue researching the drug, to search for new indications. And that disadvantage could have a huge negative impact on mental health illnesses and innovation for addressing mental illness. And the reason why is the body. Our bodies are really amazing when you think about it. And if you think about how our skin works, it forms a protective barrier, keeps all kinds of bad stuff from getting inside of us and causing harm, but it's porous. So, things can exit, things can enter, but it really does provide a very protective barrier. The brain has a similar protective system and is called the blood-brain barrier. Maybe you've heard of it, but it protects our brain, arguably our most important organ, from harm from things like viruses, bacteria, or any other number of harmful things from getting into the brain. And it operates kind of like a net, keeps harmful things out, but it lets the blood flow freely into the brain to bring us oxygen and nutrients that keep our brain healthy and functioning. That blood-brain barrier also makes it harder to get medicines to the brain to address neurological problems. That can include many different mental illnesses, diseases like epilepsy, Parkinson's, even brain cancers. So small molecule medicines are particularly important when it comes to penetrating and getting past that blood-brain barrier, because they can do it pretty easily, whereas biologics cannot. So by setting up a shorter timeline, for the small molecule medicines to be on the market before being subject to Medicare drug pricing, the IRA encourages the development of biologics instead of these small molecule medicines. We all know there's a lot of unmet medical needs for people living with a mental illness, all sorts of different mental illnesses. So continued innovation is really important. We all know people that maybe have struggled. It's hard to find a treatment or even a combination of treatments that work and continue to work for someone dealing with a mental illness. We also know that R&D, or research and development, for treatments for mental illnesses can be very challenging. It takes 20% longer to develop a drug that treats diseases of the central nervous system, and it can take almost 40% longer to obtain FDA approval. Even if you think about the treatment process, oftentimes for medicines for mental health conditions, you have to be on the drug for a while before you start feeling the effects. And it can be even 30 days, sometimes even 6 weeks before the full effect of the medicine is apparent. And if you think about anyone who's gone through these treatments, not only is that the case, but then you titrate up. Is it working? Is it not? If it's not working, then you have to slowly come off the medicine and then start afresh. So as you can imagine, those timelines make it complex and add to the unmet medical needs that people with mental illnesses are dealing with. There's also a lot of stigma still. We've come a long way, but we know there's still a lot of stigma associated with mental illness that can create barriers to both seeking care, getting diagnosed, and then also staying on treatment. So being able to take medicine in the privacy of your home is a significant benefit. And for people living in rural areas, having to drive somewhere to potentially get an infusion really is not feasible for many. It can require hours sometimes of driving time. If you don't have reliable transportation, maybe you're older and don't feel comfortable driving long distances, it can mean skipping treatment or having to rely on others to get you to and from. So again, those present a lot of challenges that lend themselves to wanting and needing more small molecule medicines. The shorter timeline also limits the research and development that is done on FDA approved medicines after their first approval. So I keep emphasizing that the clock starts on first approval for a reason, because if you have a drug that works and you make it all the way through the gauntlet to FDA approval and say it works it's a good antidepressant, you may then want to test that medicine for other mental illnesses, including postpartum depression, for example, panic disorder, anxiety disorders, anorexia. Any number of other mental health conditions may benefit from that same medicine, but that requires additional clinical trials and FDA approvals. We want to encourage that. But again, the clock starts on that first approval. So that really puts pressure either to complete those trials very quickly, which can be a challenge, or just to forego them altogether, which we don't want either. Also, many medicines, particularly those that treat neurological conditions, can have serious side effects that make staying on medicine much harder. Schizophrenia is a great example of that. There's some good medicines that treat the schizophrenia, but they can create involuntary movements, lip smacking, other things like that can make it increase the stigma and can make it hard to stay on treatment. So innovation that decreases that is as clinically effective. Obviously, we love medicines that are even more clinically effective, but innovation also includes medicines that are just as effective clinically, but lower that side effect profile. And that's particularly important, again, for medicines that you have to stay on for a long time. This chart shows an example of some different therapies at risk, is the title of it, because if you're not valuing that innovation in terms of lower side effects, which is really more on the patient side, if you will, than on the insurer side, because they all have the same clinical benefit, or let's assume that, but the side effects are different. That's really important to you and I, people who are taking these medicines. But maybe an insurer might be like, oh, that was cheaper, it works just as well, just stay on that. But as this chart shows, the discontinuation rate on those earlier therapies with high side effects was tremendously greater than those with lower side effects. A big question throughout this process is going to be, will Medicare value these advances when it's considering what's a fair price for the medicine? Understanding these benefits and the impact on people living with these illnesses is really critical then. And in weighing the value here, there are a few opportunities built into the Medicare drug pricing effort that solicit information directly from people affected, but it's not clear now. They're limited in number, and it's not clear how much weight Medicare is placing on those factors. So that's something to watch as well. The initial list of 10 drugs that were the prices for which were announced last week did not have any medicines on that first list that treat mental illnesses. But there is evidence showing that the shift away, this disincentive towards away from small molecule and to biologics, there's evidence showing that shift is already happening. Because as you imagine, if you're trying to allocate resources, if you're a company and you're trying to figure out where to invest, you're investing those dollars now for medicines in the future. And so what this chart shows is it's a chart showing clinical trials in neurology, which includes mental illnesses. And as you can see then within the red circle, between 2023 and 2024, so when this law was implemented, the number of small molecule medicines for clinical trials in neurology were about 80% of the clinical trials, and biologics were about 20%. Fast forward 1 year, and it completely flips, and small molecules goes to 0, and biologics are 100% of the clinical trials. And these are for large companies. It's not even, there are a lot of impacts, and people are concerned about how smaller companies are going to fare under this. But these are large companies making these decisions today. There is a proposal in Congress called the Ensuring Pathways to Innovative Cures, or EPIC Act. If you're not really in the policy world, members of Congress always like naming their bills with ways that they can create a cute acronym. So this one is EPIC, E-P-I-C. And that act addresses this difference in timelines. So it would equalize the timeline at 13 years after the first FDA approval for any type of prescription drug that would be subject to the Medicare drug pricing program, whether it's a biologic, whether it's small molecule. And so that would remove this 4-year time difference and the financial reasons not to pursue more research into small molecule medicines for mental illnesses or any other chronic conditions. Also, early next year, Medicare will announce the next list of 15 drugs that will undergo drug pricing. There are some speculations about what those drugs might be, but we don't know yet. And as I mentioned, there will be opportunities for people to get involved. One key area that they consider, again, are the benefits. Who's taking this medicine, or who has the disease, even if you're not taking a medicine on the list, and what's important to you? What do you consider to be benefits and of value? So it's not just enough that the medicine works well as another, but has fewer side effects. And it's extremely important for people, again, who take these medicines for a long time. We don't know yet if there will be a mental health medicine on that list of 15, but given the large population size for people taking these medicines, it wouldn't be a surprise if there were. Let me move on. So talking then again about these different ways, the EPIC Act is an important one. I know both Rural Minds and the Grange have supported the EPIC Act. And as I mentioned as well, there are opportunities for individuals to get involved, to engage in these discussions of value with CMS or Medicare. So I'm going to pause there and see if there are any questions. I appreciate your time today.
Thank you so much, Candace, for helping us understand these complicated issues today. Everyone, we're now going to move to the question and answer portion of today's webinar. But before we do, I want to let you know that our webinar is technically scheduled to end around 1:45 p.m. Eastern Time. But if we have questions, additional questions from the audience, we're going to continue through no later than the top of the hour. Following our conversation, you'll be receiving an email with a recording of today's webinar and a link where you can identify your member of Congress and view message content that you can personalize in your outreach to your lawmakers in the U.S. House of Representatives, asking them for their support of the bipartisan EPIC Act that Candace just discussed. One more thing to keep in mind if you do a little research on the EPIC Act is there's more than one bill in Congress right now called the EPIC Act, as they love their acronyms on Capitol Hill. So you will be asking your lawmakers again to support the bipartisan Ensuring Pathways to Innovative Cures Act. You're going to see that acronym spelled out within the draft message to Congress that we'll provide, but we did want to highlight that for your awareness. With that, we have a few audience questions for Candace already in the queue, and we'll start with this one related to the discovery of new medicines. There are many mental health conditions that do not have a cure or treatment. How will what we have discussed impact those who are waiting for new medications to be discovered?
Well, as I mentioned, given the blood-brain barrier, the real innovation that often takes place for mental health medicines is in that small molecule space. So there are serious concerns about this difference in timelines and how we're, as I mentioned in that slide, we're already seeing a shift away from that. So we do have concerns that it will adversely impact continued research and addressing these unmet needs in many mental health conditions going forward. And so that's why we need changes, again, that kind of equalize and level that playing field so we're not creating incentives for investments to go elsewhere.
Thank you, Candace. We've got another audience question here. If I'm currently taking a capsule medication for mental health, will this law restrict my access to medications?
It should not restrict your access to current medicines. As the only caveat I will say is that we do have some concerns about drugs that do make it to that Medicare drug pricing list. And I'll explain why. There aren't any currently for mental health conditions on the current list of 10. And it won't say, oh, okay, I'm taking a capsule now, this bill is going to make it so it's an infusion. That's not what we're talking about here. It's more future innovation. Will it take the form of a pill or capsule, or will it be more an injection or infusion? With the current law, though, if your drug is on one of the lists for negotiation, Medicare does require health plans to cover that medicine, but they're not requiring any kind of better access. So you still may have to face step therapy, prior authorization. It may be higher copays or on other access restrictions. And that, again, is something we're watching very closely because sadly, it is in the health insurer's interest to favor medicines where they get more of a, make more money on it, whereas they may actually not make as much money on these drugs. So that is something we're watching, but it should not affect access to your capsule, having it converted to some other form.
That's really good to know. No disruption in current access, but definitely on future innovation and new drugs coming to the market. Another question, Candace, from the audience. I thought the Inflation Reduction Act was supposed to make my medicine more affordable, but if I have to get future medications by injection or infusion instead of taking a pill, won't my costs increase?
Yes, absolutely. Injections and infusions tend to be more expensive than pills. They're harder to make. Think about the transportation, the storage. And also keep in mind, it's not just the medicine, but also the medical care associated with administering the medicine and storing them. So you may have to travel to an infusion center. So you're going to have to pay a provider to administer the medicine. And then there's also your costs out of pocket for time off work, travel, expenses, and the like. So absolutely, you can pretty much bet that it will be more expensive.
That's such a good point on travel time for folks in rural areas in America, right? And it's not only travel time, but it's sort of that same thought of opportunity cost, right? Not just travel, but taking time off work, taking time away from your family. And for some folks, going to a hospital for an infusion could be an hour each way or more. So that adds up when you're having to take these drugs, whether it be weekly, monthly, or at a different interval. Another audience question for you, Candace. How will I access future medicines if there are no infusion centers in my community? Will I be forced to go to the hospital, sort of along the same lines as our last question?
Sure, and that's a real issue. And sadly, it's important not just finding an infusion center. Oh, I've got one in my town, but not all infusion centers offer all infusions. So it does create a lot of extra work and challenges, particularly for people living in rural areas. Where I grew up, it was 45 minutes to go to town, if you will, and that's where we would have to travel to do this type of infusion administration. So we understand that it's a real concern and reinforces the need to protect treatment options that are convenient, that allow us to take medicines at home, to pick them up at a local pharmacy, that don't require any special care. And so that's why we're so adamant on protecting access and promoting innovation for both types of medicines, but recognizing that small molecule medicines offer a lot of significant convenience factors and access factors that are helpful.
Such a good point. And also just to the point of going specifically to a hospital, right? That's not ideal for some people with certain conditions. Just alone, the risk of infection in going to a healthcare facility, especially a hospital, goes up by so much. Our next question from the audience, Candace, for small molecule drugs, I understand the shorter timeline, but if you're creating a drug for anxiety, for example, and it meets FDA approval, the timeline starts. When that timeline ends, why are they not able to continue studying the drug to see if it will work for other illnesses?
They can. The big difference is if I've got, so say I create a great anti-anxiety medicine, it's a small molecule medicine, that's my first FDA approval. Well, I've already talked about that the timeline for clinical trials in mental health take a little longer. FDA approval takes a little longer. So your clock starts running. So if you can get your clinical trial up and running like at the same time or within a year and can finish it in 2 or 3 years, then you still have time built into, on the back end to before that 7-year time frame or 9-year time frame kicks in. But it does affect, is it worth that investment? Is it worth, if I'm going to do one indication, or maybe it's good for 5 different mental health conditions. I'm not going to have time in that 9-year time frame. So I'm going to have to pick and choose which ones that I do. And sadly, we're the ones that lose because my unmet medical need may be a small population that they would have done the clinical trial on, but for the shorter time frame. And then therefore I'm losing out. The industry is very innovative and they'll, work around this, but the challenge is we know, experts all agree, there are going to be fewer drugs. It's just a question of in what diseases and who's going to miss out. And sadly, this is an area of a high level area of unmet medical needs. And candidly, a lot of assumption out there that, there are enough antidepressants, there are enough anti-anxiety medicines, you can find something that works. And we all know that that's actually not true and not true for a lot of people.
Very helpful. Now, looking forward, we're talking a lot about the future here when we talk about innovation, but let's talk a little bit about what's going on in current events with the fact that now, no matter what, we're going to have a new administration, right? No incumbent is running anymore for president. Is there a possibility that some of these more negative impacts that come with the Inflation Reduction Act will be revisited, especially when it comes to mental illness therapies?
We certainly hope so. And we were thrilled to see that the EPIC Act, the Ensuring Pathways to Innovative Cures, is a bipartisan effort. And we continue to talk with lawmakers on both sides of the aisle. And that's why it's so important that they hear from people living in the communities that they represent, that this is important to them. So we are encouraged that there are both Democrat and Republican lawmakers who are interested in making these changes. It is a signature achievement of the Biden administration, and you hear a lot about it in the upcoming campaign as well. So there is some reluctance to make these adjustments now. We'd like to see it as soon as possible because we're already seeing the investments shift, as I showed in that chart. So we're hopeful that, from hearing from people, hearing from the voters who support them, that more lawmakers will get involved on the EPIC Act and get that one across the finish line. It doesn't repeal the law, the program still stands, but it does equalize the level the timeline, and that's really important.
Yeah, a really simple bill when it comes down to it. It's short and sweet. A question here, I think it's sort of a follow-up to one that we already discussed. Someone said, you said that a medication that has been approved for one diagnosis starts the 9-month fuse. So if that same medicine is tested for an additional diagnosis or indication, a new fuse isn't set for that new diagnosis or indication?
No, that's you're right. Yeah, it starts with that first approval. And so to your point, it's a big disincentive. Unless you can complete clinical trials quickly, you can get them off the ground, you can enroll quickly and finish them quickly. That timeline really shortens the opportunity for new indications. And that's really sad because drug discovery is pretty tough. I mean, we can find there are a lot of medicines that work well in the lab, but are toxic or have side effects that, cancel them out. They don't make it through the process, or maybe they work in models, but then you put them in humans and they don't work as well. So once you have one that's approved, the safety profile looks good, you know it works, it's really important to be able to test that medicine to see if it could work for other diseases. And particularly, we know in the high areas of unmet need, like in mental illnesses, it's really important to be able to do that. And especially when you have a good side effect profile, because we know when it comes to treating mental illness, that side effect profile is really important to people being able to stay on therapy.
Certainly an unintended consequence there. Thank you for providing more color. When it comes to the companies, the biopharma companies that manufacture these medicines, what are you hearing that they say the impact is going to be specifically on their research and development program, sort of in a broader sense?
Well, until I'd seen that one slide I shared, there have been more anecdotal. There have been a lot of comments by CEOs of the big, of many pharmaceutical companies, and they're saying, hey, they're canceling clinical trials, they're rearranging their programs, they're rethinking the approach in terms of, do we go for one indication, or do we do a huge clinical trial and try to get multiple out of the gate? So it really is kind of changing the thought process, and candidly, they have to look at their bottom lines, and clinical trials are really expensive and risky. So, you know, is the calculus going to be that maybe we don't push into an area where there really is a lot of unmet medical need, but our knowledge isn't as strong there? So maybe we, you know, stick with stuff that we do know. And so it's just a loss for people in general, and particularly people dealing with serious chronic illnesses where the unmet medical need is really large. One other thing I just wanted to mention about small molecule medicines, that if you think about it, it's really important in rural areas, again, for the access, but it also impacts our troops overseas. If you think about in terms of being able to get medicines, they don't have the storage, cold storage and other things for infusions. So that's another area that, you know, is similar to this, you know, similar circumstances, but really important to kind of think about as we think about the importance of these types of medicines going forward and the need for more innovation in that space.
That certainly puts convenience in a whole nother light when you talk about, you know, the ability to utilize something in pill or capsule form. Candace, this is just sort of a follow-up question. You keep talking about clinical trials and sort of the risks involved. How long does it take for a drug to go through a clinical trial? And when you say they're risky, how often do they succeed, a drug going through the pipeline of clinical trials?
The failure rate is really high, and it can take, you know, 10 or 12 years, depending on the disease area, for a drug to make it through, sometimes up to 15 years for it to make it through a clinical trial. So it's a really, you know, it starts out with the safety and the toxicity screen, starts out, you know, very early. Does it interact with the, you know, target in the body that we're talking about? And then it goes on to, you know, full scale, where you can have thousands of people being tested. You also have, you know, it's a global effort too, because, you know, what's required for something to be approved in Europe may be different than the US. So that also adds into the complexity, the time frame, and the expenses as well. But it's a high failure rate. It's a risky process, but obviously so important for all of us going forward, that they are, you know, that they continue to take these risks, and particularly in areas where there's a lot of need and people need newer and better medicines.
And correct me if I'm wrong, but I believe the failure rate is somewhere around 90+%, right? So 9 out of 10 drugs that you put in the pipeline for a clinical trial will never be a drug on the shelf, right?
Right. And it's even higher when you start further back in the process, as you might imagine.
Yeah, that makes sense. This one's a little more specific. If I need to go to an infusion center, I'm going to need to go to a neighboring state, and I'm fearful my insurance won't cover the treatment out of state. What are my options then? That's something that I know so many rural communities, especially in whammy states, are dealing with all the time.
Absolutely. And you know, I'll give you an example. I used to live in Charlotte, North Carolina, which, you know, you could drive 2 miles and be in South Carolina. And that was a big issue for Medicaid patients because you couldn't transfer into North Carolina, even though the bigger children's hospital was in Charlotte. So these types of issues are really important. And, another thing for policymakers to understand, that how these have these unintended consequences, if you will, down the road for real people living with real challenging diseases. The only thing I could say is finding out, talking to your insurer and finding out, what is an in-network provider. Maybe the one in the neighboring state is the closest, but unfortunately you may have to traverse across your state to get to one that's covered. And that, provider access is another huge issue. And something that's not necessarily considered with the small molecule, but that takes away a lot of those challenges when you can just take it at home.
Yep, absolutely. Another question here. This person said, we've been talking a lot about mental health, but a family member of mine also has chronic heart conditions. Will these concerns also impact non-mental health conditions?
Absolutely. And in the first list of 10 drugs, a number of them were in the diabetes space, heart disease space, and the like. So a lot of medicines, as you might imagine, for heart diseases are pills. And so they are any disease that is, that uses pills or patches or like is affected by this change in law. And in particular, diseases like many heart diseases, which are super common in Medicare. And so that total cost for Medicare will add up quickly, and have been. They're in the initial list of 10. I think the majority of them either treat diabetes or some kind of heart condition. So that is a great point, and appreciate the question. It does impact all diseases that rely on these medicines.
I'm going to lump two questions here together, both dealing with advocacy around this topic. The first is, as a rural patient, how much impact will my voice really have on supporting the EPIC Act? And the second sort of follow-up is, beyond contacting my elected officials, what else can I do to make my concerns heard?
It's a great question, because I think a lot of times people underestimate the power of hearing from voters. You should not be shy about letting your policymakers know who you are. And they do listen. They listen more intently to people from their district. And if you are, hey, I'm dealing with these issues and I'm concerned, where are you on the EPIC Act? They may not have even looked into the EPIC Act. I hope they've heard about it, but your letter or your call will make sure that they do, because any office you write into or you call into, they will send a response, and that requires their staff to look into it. And so that's why it's also really important to have your voice be heard. One time is great, but if you send in a letter and you get a response, or, call them back and say, all right, I'm calling you back. Have you changed your mind? I'd like to talk to you about this. Huge impact. Handwritten letters, they hardly ever get any handwritten letters. Things like that really make you stand out, but that you're persistent, make a big difference. They will remember you.
Yeah, and just to add to that, I'll say that most members of Congress will not do anything without first hearing from a constituent. And especially in rural states, the opportunity for them to hear from constituents, whether that's because it's harder to travel to Washington, D.C., or there are just fewer people there to be reaching out, means that your voice actually has a greater impact, right? There are fewer of you in many cases in the states that you're living in. So really understand that you have so much value in the process when it comes to advocacy and outreach to Congress. With that, I think we have run through all of our audience questions. As we close the question and answer portion of our webinar, I want to remind everyone to keep an eye out for a follow-up email that includes a recording of today's webinar, and to utilize that email and phone message template to personalize your message to Congress on this issue, requesting their support for the bipartisan EPIC Act. With that, I'll turn it back over to Jeff Winton for some closing remarks. Thank you.
Thank you, everyone, and thank you for the excellent questions that were submitted. And Candace, I'd like to thank you for sharing this very important information with all of us. I know that I learned a great deal, and much of this is impacting me and my family because we live in a very rural area on a dairy farm in upstate New York. And so this is very personal to me and something that I need to learn more about as well. So thank you for sharing your experience and your expertise and your knowledge with us. Matt, I'd also like to thank you for sharing your expertise and for the great job you did of moderating the Q&A. I believe we had some other questions come in as we started the wrap up, and we'll make sure that we get some answers to those and post those on our website. We'd like to thank our presenting partners at the National Grange and Burton Eller in particular, and our sponsor, the Grange Advocacy, for helping us to put on this informational webinar. And of course, I'd like to thank all of you who have joined us today. This was, again, a very well attended webinar, and we know many other people will be accessing the recording once it's available and posted. For more information about the National Grange, please go to nationalgrange.org, and please also visit us at ruralminds.org to learn more about the work that we are doing. We will have the third webinar in this series conducted on Wednesday, September 25th at 2 p.m. Eastern Time. The topic then will be the need for pharmacy benefit manager reform in relation to the Inflation Reduction Act. So please be on the lookout for notifications on that, and we would appreciate it if you would share with your friends and family about this valuable service that these organizations are providing. So with that, we'd like to thank you again and have a wonderful day. Bye-bye.